um, that we come across every day while in EMS. Um, and we're gonna just it's an overview. Oh my god, by one. Right. So it applies to the fundamental knowledge of emergency medical services and systems, safety, well-being of the emergency medical technician, um, covers medical, legal, and ethical issues for emergency care. We, like Kevin said on Thursday, a lot that we do is governed by law, even though that we don't see it directly. Um, there's, I don't know about Maine, but New Hampshire is there's like a whole RSI section just for EMS and what we can do and not do. Um, so we're going to talk about medical, legal, oh my God, medical, legal, and ethics. So we're going to do consent to treat and transport, and we're consent for refusal of care. We need to talk about confidentiality, which is HIPAA, advanced directives, um, tort and criminal actions. Excuse me. Evidence preservations and statutory responsibilities. Um, mandatory reporting, ethicals and principle, moral obligations, and end of life issues, which you'll come across in your career if you go into EMS or fire. So a basic principle for EMS is do no further harm. Generally, when we are called to scenes or to people, they're at their worst, and it's our job to make at least stabilize them to get them to the ER. And but if we make something else a problem or make them worse when before we get there, um, that's when we run into legal issues. Um, and the way we uh, stay out of trouble is like we're acting in good faith of the patient and that we are acting in the standard of care. So like when if I go for somebody that's in a cardiac or having a cardiac episode, there's a standard of care that's expected of me. And then like if you're like as an EMT on scene, there's a standard of care for you guys um, that you need to follow. And if you go below the standard of care, that's when you get into negligence. Any questions? You guys hear me, see me okay? Good. All right. All right.
We can't see you.
Oh, sorry. Yeah, but see the slides. I can pull up my camera in a second after this slide. Um, so consent, like every run that we go to, we need consent to treat a patient and transport a patient. Because sometimes family members or whatever or bystanders will call for ambulances, and we show up, and people will just say, not even know that we're coming, and then if we just can't, we don't have the right to just throw somebody in the back of an ambulance and bring them to the hospital or treat the patient without their consent. So there's different kinds of consent, which we'll get into. Um, so they have to have consent to treat the patient and transport. The person must say, "Yes, you can treat me." Well, in a way, and the person has to be conscious and be able to make conscious decisions to have a legal right to refuse care. So somebody who's underage does not have a legal right. But we also don't have a legal right just to, well, you're underage, we're going to go to the hospital. So we're going to be conscious of that. Um, so the foundation of consent is the decision making capacity. So somebody needs to be alert and oriented and know what's going on around them. So even though it kind of sounds silly, if like I don't want somebody says I don't want to go to the hospital, or whatever, like the first words out of my mouth or my next words are, do you know what day of the week it is? Do you know what month it is? Do you know what year? So we need to make sure that they're alert and oriented to be able to understand what they're decision making is. Um, so we give them and then we also give them information about refusing care. Um, and then we have to inform them the choice of regarding medical care. So if we give them a treatment like I just can't stick somebody with an IV, I have to tell them why we're going to start an IV, like if they need fluid or if we have to give them um, medication or they're going to give medications in the ER. It's better to have it. And patients do have the right to like decide what their care they're going to get. They can say, "I don't want an IV. I want to wait to the ER." But then we document later on, like patient didn't refuse the IV. So express consent, like I said, there's an express consent. Oh my God, what's the other one? Implied consent and informed consent that we go through. The three,
What
the three.
about
Yep, yep.
involuntary?
That
That
is
is
coming up.
coming up. Okay.
Um, so the patient, like you walk into a patient's house or like on the side of the road, wherever the patient may be, um, and they said, "Yes, I want you to treat me. I want you to go to the ER. Like I having chest pain, I need to be seen." So they have expressed consent uh, to be treated and transported. Sometimes, like, "Hey, my name is Morgan. I'm a paramedic with Berlin. Can I look at you? What's going on?" Like before I even touch them, I should have consent to touch. And then that's when I grab their wrist and like look them over or whatever. I mean, they could say, "No, I don't want to be. I didn't call you. Get out of my house." Then like, okay, can you sign here? And they say no. Then we get a witness or we document um, patient refused treatment, said get out of quote unquote get out of their house, and then we have to inform them of like if the risk of not going with us if they're having chest pain and like I don't want to go to the hospital. Okay, that's great, but understand that we could be tied up with another call if you need us back, or you could ultimately die of a heart attack if you do not go to the hospital. So you need to inform them of the risk that they're taking. Implied consent, we deal with a lot as well. Is for somebody who's unresponsive or it does not have um, co- decision making capabilities. So somebody who's having a hypoglycemic event, or like like their sugar is low, or uh, post-ictal from a seizure, or underage, or whatever it may be, that they're just not able to comprehend what's going on around them. So if you say, "What time of year is it?" and they're like, "Oh, it's Christmas," and it's actually in June, uh, obviously something's not right. So they need to be treated and transported, and that's when you can just it's implied. So somebody that's unresponsive, like somebody who says OD'd, technically we can just pick them up and put them on a gurney and bring them to the hospital because we're in good faith of the patient and they do not have the uh, capacity to say no, I don't want to go to the hospital. Um, so and also if they're not, if they say I don't want to go to the hospital, it's a good idea to get vitals. Like with SaO2 needs to be 94 or higher. Blood glucose needs to be in range because patients are very good at compensating, and sometimes they'll have a full-on conversation with you, and then something's off. Or if a patient's like who just had a seizure and it's coming out of it, it's post-ictal, they will become or can become combative, and then like I don't want to go to the hospital, but um, they don't know where they are, who they are, or what we're doing there, and they're just in a flight or flight mode, and so they don't really understand. So yeah, it should be never used unless there's life threat of life or limb. Uh, Principle of implied consent is known as emergency doctrine. Like, so if it's an emergency and we're acting in good faith, it wouldn't be negligible or assault and battery. But we'll get into assault and battery sooner or later on. Um, so if somebody, relatives around or whatever, get consent from them if like instead of just taking off and say it's implied, like you can get um, consent or tell them what's going on with the patient or why you're doing what you're doing. Any questions so far? No. Alright, so involuntary consent, like somebody brought up earlier. Um, so um, I deal a little bit with involuntary consent in Berlin. Um, so again, it goes along with somebody who has to have the capacity to make decisions, informed decisions. And so if somebody's mentally ill uh, or behavioral crisis, like if somebody is just having a psychosis or on some sort of narcotic or drug, or if the development may be delayed, but they're in emergency, we can just kind of snatch them up and bring them to the hospital. As long as we're doing it in good faith and not just because. So we also have to get obtain consent from a guardian or somebody or an officer that's there, if there's somebody available. So a parent or legal guardian can give consent for minors. Um, so I think it's like I don't know what it is in Maine. I th- In New Hampshire, I believe the age limit 16. That they can be considered an adult. Also, if it's minors becoming emancipated if they're married of a certain age and armed services or parents. If they have kids of their own, they can make their own decisions. So teachers and school officials may act in place of parents as well. Um, so my wife's a school nurse. I'll give you a little story about that. And somebody hit a bus, like a slow action. There was just a little fender bender, but there was just like 20 kids on the bus, and so somebody called 911, and of course the provider who was there is like, "Oh, we have to transport all the patients," and she said, "No, we're not transporting them. Like, I'll sign them off." And she has the capability of that because the parents are putting their care of their children in the place of the school and the teacher. Um, so if there is a minor around and it's a true emergency, you feel like it's a true emergency, treat the patient and you'll have them comply consent. Kind of like ask questions, act now, ask questions with forgiveness later. Uh, so forcible restraint, uh, I deal with that every once in a while too. So sometimes like there will be combative patients, like I said, somebody's on drugs or post-ictal or psychosis or whatever, maybe we can uh, restrain patients. Like EMTs can use cravats or whatever and tie their hands and legs down. And it's good training, like if to do it separately, is to like have one person on each limb, and like you really need 5 people. And if you get law enforcement, if it's like unsafe, and they will help. And also, like if you ever do restrain patients, it's a good idea to get medical control and call just to give them a heads up and give them the scenario and see what they want to do. And like everybody wants to go home safe and sound at night, so like just quickly as you can get them restrained. Um, yeah, and once you do have somebody restrained, don't unrestrain them because they can, like, even if they're acting like they're calm and cool and collective, as soon as you let an arm loose, like they can do a lot of damage. Yeah, and call for ALS if you ever do that because they can pharmacologic do use drugs, medications that we can restrain patients with. Questions, comments on restraints and consent? No? Okay. So patients also have the right to refuse treatment. Like a lot of We get a lot in Berlin actually. Um, the caregiver will call, like, they just get nervous or whatever. So they'll call for us, and the patient's like, "I'm fine. I don't wanna go." And they have that right. And every patient well, except for as long as they have the mentation, they can refuse. Um, and I did read about a law case or a case where a patient refused, treatment and then later on passed away, and the court, favored and they had a signed refusal, informed refusal, so the court, favored the EMS providers. S So, yes, the calls involving refusals are frequently litigated, because that's I think I document the most on refusals, because that's what your saving grace is in court, and that it can come back and bite you. So yeah, and it's a good idea to involve medical control and document what they say, your conversation with them, and it's best to have it on recorded line. So you can just give them the scenario, and then they can make the final decision. But make sure you document very well what the conversation was. So you got to assess the patient's ability to make an informed decision of what happens if they refuse care. So again, you got to make sure they're alert and oriented, that their vitals are within normal limits. So like SaO2 above 94, blood glucose above 80. Um, they know where they are, what they're doing, why they're there. Um, if a patient appears confused or delusional, you can't assume that they can refuse treatment. And sometimes like you can just coax them like, okay, let's just go for a ride. Like if somebody has dementia, they can really kind of fool you, and then they like all of a sudden come out of the blue like, oh yeah, that they're not right with it. Providing treatments more defensible. So if you do go to litigation, uh, it's more defensible that you did treat the patient in good faith rather than just sign them off. Don't yeah. So and if somebody is combative, like just back out and get law enforcement involved. Um, and if it's their behavioral whatever, they'll bring them to the ER. Uh, Releasing encouragement. Yeah. So again, this encourage an individual to allow care, like at least if there's something going on, if they're having chest pain, like okay, can you we at least take a picture of your heart and put them on a 12 lead or a monitor, take their vitals, like okay, like, make sure you do a thorough exam. Um, Always get a refusal if they're refusing care and you think they should go. Um, have a if like a witness, a third party member, like other than your partner, like sign on refusals as well. And again, document like the conversation, um, that happened. If you use medical control, who it was, what was said with the patient, and use a lot of quote. You can quote in your reports about what was said. I guess that's has a lot of value in court. So any questions, comments on refusals? No. Okay. So confidentiality, it's huge in healthcare. Uh, you got to be really careful. Like it's sometimes you get going on like really exciting calls, and then you want to tell everybody about it, but you really can't. You really shouldn't. And I've had to talk to providers about that. Um, so like patient history, like confidential information is patient history, like their name, address, date of birth, things that you found, like and the treatment that you provided. But like if you say like you can always just give it to the refuse like all the information the receiving facility because of continuation of care, and the reports will go with them as well. But you can't go up to the janitor after I'm like, hey, I just went on this really exciting call, or you go out to the bar because like everybody knows everybody, and it gets around, and sometimes it doesn't need to be in public. Um, so if a patient signs a release, um, obviously you can get that release the information then legally subpoenaed, and if billing, like our billing people, read our reports so that they can properly bill them. But they only read sections. They don't have the name and date of. Well, they do have the name and date, but they only read sections of it, like the narrative. They don't have like detailed information. So yeah, the Health Insurance and Portability Act, so HIPAA, it strengthens privacy. Like and we have to have patients sign stuff saying that we offer them the HIPAA Privacy Act and all the information that we cannot disclose their information to the public and whoever. Um, Failure to abide by HIPAA laws, you can be sued and lose your license, or they can if you ever get articles, you can there's articles about where like I read something about a doctor who had a hard drive, he forgot it in a taxi or whatever, and he found it and he like self turned himself in to the HIPAA, the Medicaid, Medicare, which governs it, and he was fined quite a lot, and you can end up with jail time as well. But yeah, the public will record or can take pictures, but they really shouldn't be, and we try to block that out or get them away or move our apparatus around so they can't take pictures and images and videos because everything's on YouTube and everybody has a camera now, video. Um, yeah, if you use social media, and it's anything like with it gets good. Like you want PR, but just make sure when you do it professionally and like there's nothing with patients or their addresses involved. And if you use um, post stuff on Facebook or like social media, make sure you're doing it professionally because everybody knows everybody and it comes back. And even though like there is free speech federally, if you don't want to badmouth patients or people that your employers or your agencies, because even though federally you have free speech, you can't do it like that. So advanced directives, this can be kind of a thick as mud sort of thing. It can be confusing. So a DNR, if somebody like goes in cardiac arrest, there's no pulse, um, no breathing, they can have DNRs, which is a type of a directive that they don't want CPR done or they don't want to be intubated. Um, and there's been a time or two like we've started CPR and then all of a sudden somebody hands us a pink slip, or I don't know what they look like in Vermont, but I mean, excuse me, Maine, but in New Hampshire, they're like big pink paper, pieces of paper or bracelet. Um, so and then we just stop CPR. But um, then if there's any question, they just call medical control. And then if somebody like you're doing CPR and like, okay, they have a DNR, like, you need to kind of uh, you need to show it to us, or else it doesn't mean anything. But family members can revoke DNRs also, and um, can tell you to stop CPR. But again, use medical control. Living wills and healthcare directives, or other kinds of advanced, yeah, directives. So, like, if I become unresponsive or I can't think or function for myself, like my wife will be my proxy, so she'll tell them to pull the plug, sort of thing, or make the decisions that I can't, but she'll do it in good faith of what I want. Um, Is DNRs again. Yeah, they must have the medical problems on. So everybody that's on hospice gets one, obviously, but they have to have why they're on have a DNR. They have to have the patient name, signature, and the physician. And I guess they expire. That looks not like ours, but I guess that is advanced directive. Uh, so physicians order life-sustaining treatment and medical orders for life. Oh, yeah, so I guess it would be kinda like a do not intubate order or what the patient wants, so maybe a patient doesn't want IV, maybe they don't want all the heroic efforts, or maybe, like, if they have, diabetes, that we can give them, D10 or glucose or whatever, but we can't do CPR or go, like, above and beyond. Um, again, use medical control. So yeah, patients have surrogates, like a durable power of attorney. There you go. That's what I was looking for. Um, so if like I'm incapacitated or a patient's incapacitated, healthcare or somebody can be their proxy. So yeah, and like we get home hospice all the time, and it's sad, but you kind of have they call us just to say, yep, the person's no longer with us, and we shouldn't be doing CPR. So this goes into physical signs of death, um, because there is sometimes question of a patient's dead or not, or if we start CPR or we don't start CPR. Um, so if somebody is presumptive dead, like if you do a sternal rub, they don't groan or anything like that. There's no carotid pulse or heartbeat, apical heartbeat, no breath sounds. Like you can touch their eyes or they're everywhere around their eyelashes, and they should blink, and if they don't, it's a good sign that they're no longer with us. So no systolic blood pressure, obviously, because there's no heartbeat. Profound cyanosis, that's when somebody's blue. Like cyanosis, cyan is blue, osis is like skin. And lowered or decreased body temperature, because once we die, we're not producing heat, so our body will go to ambient temperature. So this is lividity, and that's what happens when the capillaries and the vessels just kind of open up and the blood just oozes out and then down. It follows gravity. So this patient was like obviously supine, and then somebody put their hand on her, her, and so that will start happening within a few minutes of if CPR is not done. Like within a few minutes, it'll start happening. Decapitations, it will be is a definitive sign of death. Another rigor mortis is a definitive sign, um, which generally starts in the jaw. Weirdly enough, so like if you try to put in an airway and like all of a sudden you're like, oh, their jaw's not moving, that's starting to be rigor mortis. Cooling of the body, and putrefaction uh, will start happening, I guess, within 4 days. It's really gross. Um, so we're lucky in Berlin because like the cops go on all our most of our calls, but everything that is suspected death, they definitely show up, and so they handle all the patients that don't make it, and they call the examiner, medical examiner, and the district attorney, and to see like to investigate or whatever they need to do. If it's not considered a natural death, they'll start investigating it. Um, like if somebody obviously is older, like has a whole bunch of meds, it's probably a natural cause. But if somebody is like s- suicide, violent death, then they're definitely gonna um, investigate. If you're younger patient, they're gonna investigate. Um, uh, so death of accidents, suspicion of a criminal act, um, like infant and children deaths, they're definitely going to be investigated. Special situations, organ donors, they'll take care of all that in the ER. Party, oh yeah, so yeah, it saves other patients' lives, and we need to oxygenate. Um, but in New Hampshire, I don't know for Vermont, we don't transport anymore for codes. So, and that is a organ donation card. So special situations, medical identification insignia. Yeah, so if somebody's unresponsive, look for s- the bracelet necklace for the medical ID stuff, and like they have their history or whatever. And apparently they have flash drives as well. It's interesting. There it is. Yeah, medical alert bracelet. Um, which actually I did use one once, and it was glad he had it. Like an unresponsive patient, like nobody even saw him. Like we just called it unresponsive, but it ended up having diabetes. But we gave him D10, and he still didn't come around. But we transported. Um, so yeah, if you look, always look for this. You should be looking for this when you're doing a patient history and they're unresponsive. Uh, yeah, scope of practice is like our state medical control dictates what our scope of practice is, and I believe the modules are in here. I remember Kevin saying that. Uh, like in New Hampshire, we have to follow protocols. So, like if somebody's having chest pain, we follow the chest pain protocol. If somebody's hypothermic, we follow the hypothermic protocols. And like I have an app on my phone, and it's if we get toned out and it's something haven't been to for a while, I always read up on my protocol before we get on scene. Oh, yeah, so outline, yeah, we did that. Carrying out procedures outside of oh yeah, we can't go above and beyond what our scope of practice is. It's if something goes like if it goes right, you may be a hero, or the state will find out, and you might not be a hero after that. And if something goes wrong, it's negligence, and you can be a criminal offense as well. Um, so standards, we always need to show respect for our patients and be concerned for their safety and the welfares of them. Like we always just like see this guy, the provider is like down at the patient's level. He's touching her. He's being kind. Like he has good posture and like just showing empathy. It could go a long way. Standards of care established by local custom law, like our like oh my god, there I go. So law, we have RSAs that govern us that are go up to the state level registration, but then we have a medical board and the trauma board, I believe, that dictates our protocols, and we have like a state um, medical direction, so that they do decide what we can do and not do, depending on our level. Um, we have professional standards like our CPR guides, and like our standard of care, our textbook, we're learning our standards of care right now in here. Uh, so Medical Practice Act. So we have there's like certain ways there are levels that we go by. There's certifications. Like when you get done this course, you'll be able to take the national registry, which like you can't just go out like, okay, I have my EMT, I'm going to start practicing as an EMT. Like, you need to prove like that you're competent in what you learned at a baseline. So that you have to take the national registry. The national registry says, "Yep, um, Oregon's good to go. He's proven his level. He's knowledgeable of a paramedic level." So then I gotta go apply for a license for the state of New Hampshire, and then I have to like do a background check or do make sure that I know my scope of practice. I got to take that test and my protocol test. They're like, "Yep, now you can practice as a paramedic or an EMT." Um, which is, I guess, it's the same as credentialing. Yeah, so the whole process is just credentialing. Um, Duty to act. Uh, so in order to prove this is like segueing up to negligence. In New Hampshire, like if I am on duty, I have a duty to act. Like as soon as that tone goes out, it's my duty to make sure I bring this level of expectation of care to that patient. Like if I'm not on duty, and if there's a wreck in front of me, I really don't have a duty to act. But if I do act and something goes wrong, like I don't have that duty. So therefore, there's a question of if I was negligent or not. So if I'm on duty, I have a duty to act. Once the tone goes off, I have to respond, due regard, um, with the ambulance, and then follow whatever protocol I deem fit. If somebody's having chest pain, I'm gonna go down the chest pain protocol. So yeah, and if I'm not to prove negligence, if I have the duty to act and somebody's like my chest hurts and I'm like, oh, you probably just have pneumonia, and treat them just with oxygen or nebulizer, and they end up dying, they're gonna call somebody who's similar training as me and like, well, if he's having chest pain, he probably should have followed the chest pain protocol. And so therefore I was negligent. Like so Kevin would get on the stand against and say, nope, it was chest pain. He should have done this and he didn't. So um yeah, the four elements that need to be present in order to prove negligence. And this is a good thing to know is duty. Like, did I have a duty to act? Did I breach that duty? Like if I was like, maybe I'll go on this call, maybe I'll send a basic crew. Um, if something cause of it, if there's um, somebody had chest pain and I just didn't give them aspirin or nitro like I should have, um, and they had suffered like a heart attack, and I would be um, responsible for the damages caused by that. I have no idea what that last word is. Oh, cause and effect, causation. So yeah, a relationship between the breach of duty and the damages. So because didn't act within my scope of practice or I breached the duty, um, this patient died because he suffered a major MI. And there's some Latin for you. Res is sapa loquitur. I don't do Latin, but it's the cause of the injury was in control of the EMT. So if, which does not occur unless there is a negligence. So like because you didn't check a blood glucose and the patient ended up dying because you didn't identify that, um, that was negligible. negligence per se, the conduct of the person being sued is alleged to occurred in clear violation of statute. So you broke the law and something bad happened because of it. Torts, we don't really get into much in a career. That's more civil, but people can sue you for civil issues rather than like criminal issues. Is if the law, like if I broke a law, like if I was speeding and got into an accident, that would be criminally charged. And then the patient's family could sue me for civil liability. That would be a tort, the suing because it's civil. Abandonment, sometimes is like when if s- you have a patient and your patient is in your care, you have to see the care through until you get the patient to the hospital. And you have to go to an equal or above um, provider. So if you bring a patient to the hospital, you can't say, "Oh, there's an LNA, just sign here. I need to." There's another call. You have to give report and give all the information to the RN or physician on duty. But so if you came on scene and then you called for ALS, you can like give care to an AEMT or a paramedic who then has the patient until they carry it through to the ER. So yeah, an abandonment may take place at scene or in the emergency department. Like, so if you just tell the patient, "Oh, you don't really need to go to the hospital. Like, you're fine. Just walk and clear the scene," and then something happens, then that would be abandonment. Or if if a patient calls 911 and they want to go to the hospital, just to go to the hospital, you have to bring them in a way. So and also again, like if you bring a patient up to the to the ER and or even to the floor if you're doing a transfer, you have to give report to an RN or a physician. Like an LPN is questionable, but sometimes that's all you can get. Always get a signature of who you gave report to, and I always like when I give a report, like I ask their name and I make sure I put it in my reports, my narrative document it. I gave report to Jane Smith, RN, and then she signs whatever paperwork I have. Assault and battery. I don't know why I didn't move this up. So, any questions with anything we covered so far? We're almost there.
Yeah, Morgan, I have a question. It's Morgan, right?
Yes, ma'am, sir.
Yeah, this is Jason Sear. So as far as you saying, like, if we were on duty, we're kind of supposed to help somebody when we go out on a call. But if we're just out, shopping with our kids or whatever, and we see somebody go down, we don't have the duty to help.
Right.
But if we were to help them, would we fall under like the Good Samaritan type of a rule, for basic first aid and
Yes.
CPR, or would we fall under,
You would fall
our
under
license?
Good Samaritan.
We would.
So that's a great question.
Mhm.
You would fall under Good Samaritan. Um, I know in some states you are bound to react if you like if you're licensed and somebody sees you go by an accident and you don't stop. Like
Mhm.
you, that's not the case in New Hampshire, but there's a duty to act like in that case. But if I go to Maine, I do not hold a Maine license. So if I go to Maine, I'm just somebody who knows a lot of first aid.
Yeah.
So if I just wind up on a car accident scene and something happens, I'm the thing is for Good Samaritan, A, do I have a radio? And I'm expected to go to the calls, yes or no. It's like I don't if I'm not on duty, I generally don't carry a radio.
Yeah.
B, I'm not expecting to receive any payment if I'm like out on
That's a Good Samaritan rule.
whatever.
Yep. Yep.
Yep, I'm not receiving payment, then I have no duty to act right then. So then
Mhm.
that's Good Samaritan.
And as long as you don't go above and beyond your training, I believe too. I think that's one part of the wording in
Right.
the Good Samaritan rules. All right. Thank you.
Right. Right. I couldn't just go to Maine and like something happened. Like if a ambulance showed up and just start an IV just because I can, what I don't know. I could ask for permission later, but it depends. It's a case on case basis. But it's just good to do your first aid, CPR, and like as long as you're in good faith of the patient and not going above your scope of practice. But again, like if I don't hold a main license, I would just be doing a lot of first aid. And if
So
something
kind of
happens, yep. Go ahead, Kevin.
no, to kind of add to that a little bit. So one of the states you're talking about, Morgan, is Vermont. So Vermont,
I
if
don't know.
you're
I keep
driving,
saying Vermont.
no, but Vermont is
Yeah.
one of the states where if you have an EMS, if you hold an EMS license and you have any insignia on your vehicle and you choose not to stop, you can be held liable for not stopping. You have to at
Right.
least make an attempt to say, "Hey, you all set?" If they say we're good, then you can just keep going and drive on. Um, the other thing about the whole duty to act. So obviously, if you're a volunteer, let's say go back to there are still some volunteer services out there. If you're at home and your pager activates, you're not held to duty to act. You have no duty to respond unless you are on a call schedule. So if you're signing up for a volunteer call schedule, let's say 7P to 7A, and you don't go and your name's on a schedule that you should be responding from home, then you have a duty to act. But if you put this into the interfacility transport, let's talk about IFT for a minute, because some of you may actually go down that road where you want to do interfacility transport. There is no duty to act if you refuse to do a call because they are already at a higher level of care in a hospital. So if you get called, let's say to AVH, we'll use Berlin since Morgan's teaching today, and the road conditions are absolutely horrible. You got a blizzard condition coming in. Your crew is exhausted. They've done 4 back-to-back runs to CMC. They've been on the truck for 14 hours. They need a break. They have that ability to say, you know something? No, we're not doing this call. And they're not going to be held liable. There's no duty to act. And the flight crews are the same way. They can actually refuse a call, whether it be in a facility or even a scene call because of safety. So there's a lot of things that they can do. And the states have allowed, especially New Hampshire, an interfacility world, where calls can be refused based upon crew being tired, to unsafe conditions, to the patient being too critical. And they can, and like for example, paramedic crew who's PIFT certified in New Hampshire, if they get to a hospital and the patient is not stable, they can say, nope, we're not taking this because it's going to hurt the patient more than it will actually help them, and they can refuse it right on patient bedside after an assessment. That's the difference between 911 versus interfacility transport. 911, if you're on duty, we have to go. We have to respond and provide the care we have to do. But interfacility transport, there is really no duty to act. So we have that ability to refuse. Does that make sense? So there's a lot of different things out there. Just know what your state laws are and how the programs are run is the biggest thing. Because this is a New Hampshire class, we have to cover all of New Hampshire, but we will put in tidbits of information for like Vermont, Massachusetts, Maine as well. So we do have Maine providers in this class as well, to kind of move forward with that. So I didn't mean to interrupt you, Morgan. I just kind of wanted to go a little more in depth on the.
No, I appreciate it.
Yeah, not a problem. All right.
Okay.
All you.
Thank you. So now we're more legal. Assault and battery and kidnapping. So early in my career, I was actually almost said I was kidnapping a patient once, but my chief was driving, and like I asked the patient like if I could do something like assess him or start an IV on him, and he said yes. Then we got to the ER. Like he said he didn't want to go. I kidnapped him and like had assault and battery. And my chief called him, like called the ER. Like no, that's not what happened. So we're just gonna be careful again with getting consent. So assault, which it can be kind of confusing, like the difference between assault and battery because they're into, like you hear it all the time. Like if somebody's getting charged, it's always assault and battery. So assault is causing fear that you're going to do bodily harm to the patient or person. So if like you even like go to touch a patient and they're like shy back, that could be assault. battery is like unlawfully touching. So if I do go up to a patient and put my hand on a patient and like just to touch a pulse or whatever, and I don't have their consent, then that would be considered battery. Like I know in the movies or whatever TV shows, the assault battery is a really bad thing, like getting beat up, but it could be little. Um, and it could like even if you're taking a pulse, it can be taken out of context. So kidnapping is seizing and abducting a person, or like if we take a patient and like it happened to me, like and they say no, I don't want to go, and you do it anyways, that could be considered kidnapping. And then false imprisonment is unauthorized confinement of a person. So if we do get them in the ambulance and they want to leave, and we say no, you can't leave, um, that would be considered false imprisonment. Um, so yeah, I mean, if we start transporting a patient, this happened to me a couple weeks ago. Um, a patient OD'd and brought him to the hospital. We get to the ER. He's like, I didn't even want to go to the hospital. He like opened the doors and started walking down the road. Like, there's nothing we can do. Just document. So yeah, and make sure you always have like, and just make sure you have a your partner with you. Like, it's just to so you don't have to play the he said she said game. There's always a witness, and then always document, document, document. Defamation of character. Uh, like if you like again with the documentation, you got to be careful. Which I think we're going to be talking about next section. Is if you're saying something bad about a patient or they don't like it or if it hurts their reputation. So liable is if you I write something like if I go to a scene and I say the patient was drunk or acting drunk, um, the patient was perfectly sober, um, that could be considered liable. Slander is like I go to give a report and say, yeah, the patient's trashed. Um, so that would be a spoken word. So that would be uh, ruining the patient's character. So how would you think like I could go about if somebody because we deal with drunk people? How do you think I would document that?
Something like patient appears to be intoxicated,
Right.
maybe?
Yeah. No. Yeah. Appear to be intoxicated um,
Or
there's
slurring speech,
slurring speech,
stumbling.
smell of alcohol. Open the doors and beer cans fill out.
Under the influence, maybe
Yeah.
under the influence.
Yeah. So it's like you just gotta be careful how you document and how you talk and be cognizant of it. Because you probably in your career, if you go down to EMS, you're gonna be called to a bar, and they're gonna think they're drunk, and you don't, and you put that in their report or tell them they're actually having a stroke. That's more embarrassing than anything, though.
And we'll definitely cover more of this as well when we get into altered mental status assessment.
Yeah, definitely. So Good Samaritan laws, I think Jason brought up. Uh, if you were reasonably help another person, you'd be held liable for errors or omissions. Uh, so Good Samaritans conditions be met. You're acting in good faith of the patient. Like, so if I just go down the road and an accident, I'm doing the best I can for that patient, or I'm acting in good faith of bettering their condition and at least stabilizing it, without expectation of any compensation. And like within my scope of training, and I didn't act in a grossly negligent manner. I'm not sure how, but like if I just completely blew somebody off or just didn't do what I could do in my scope. Like, but if I'm like as a bystander, there's only a little limited amount of things you can do. Uh, Gross negligence is constitutes willful or reckless disregard. And I've met providers who did this. Like if somebody is sick or whatever, you just blow it off, or just don't, or you're tired or whatever, and you just don't really care what's going on, and something bad happens. Like if somebody calls you at 2 a.m. for vomiting, and you don't treat the vomiting, or you don't maintain their airway, and they end up dying or getting aspirational pneumonia, like they're liable for that. Um, Immunity and statutes apply. EMS, yeah, we are a governmental agency, and it provides limitations on liability. I guess that, Kevin, do you know what that means? Sorry.
Sorry, I stepped away for a second. Which one were you on?
Sovereign immunity, like there's only limited or liability.
So hold on a second here.
I guess there's only a certain amount of that people can. Oh, that we don't have complete immunity if we show negligence or have negligence. Right?
Yes, sorry.
Yeah. So like we're not completely immune. Like if something happens, which it will in your career, like you do something and you mess up, which it will happen. Um, you're not always immune from it. But if you're acting in good faith of the patient, you document. So our favorite part of EMS is like we do a lot of records and reporting. Kevin talked about like Nemesis our last class. For every time we go on a run or call for service, no matter what, we have to do a report. In which our reports could be subpoenaed or whatever. An action recorded was not performed. So yeah, if we recorded, say I started an IV, but then went into the ER and they didn't document an IV, or if I didn't and they had to start their own, then obviously I didn't do that. Yeah, and untidy, incomplete or untidy reports. If like you write horrendous, and I've seen some horrendous reports, that's the kind of care that you're showing that you don't really put much of that effort into your care, so you don't put or into your reports, so therefore you're not going to put it into your care as well. And if anybody's ever been to court, they're going to try to um, do your character, and they're going to tear your report apart just out of that for your character. And yeah, and all information that is collected, or there's a certain amount of information that's collected for the national, EMS information system, which does all the agencies in the U.S. But then New Hampshire, they collect data for just to view or whatever to see trends. And it's improve speed and accuracy. Yeah, garbage in, garbage out. And I pull a lot of not reports, but like I'll do a lot of data collection and analyze it, and especially with administration. Yeah, and you're gonna have calls that there's obligation to report. So anytime there's child abuse or elderly abuse, like I'm bound by law to report that. If anything ever comes of it, that's another story. But I have to report it, and I can't say, "Oh, the cops are already there. I don't need to report it." I need to pick up the phone and call the elderly services or child services and make a phone call myself. And everybody on that call should be doing it. Injury commission of a felony. So again, like Kevin said, like our state only has, I believe, is elderly abuse and neglect in children. Drug related injuries, well, that would go in our report. We wouldn't call the cops or anything like that about the state. Again, domestic violence, you can report it to the cops if you need to, or the police. Attempted suicides, we don't really generally for EMS in New Hampshire that we do the elderly abuse in children again. Like if this went to the ER, they would call themselves or the police, and they would just call the state and report it.
So I have a question about reporting. So if you're talking about child abuse, you have an obligation to report something. But if you've transported that child, is it the assumptive that you're going to report it as well as the hospital will do their due diligence, or does it just get reported one time?
Everybody that's involved with that case reports it.
Okay.
Like if you are on the call and you see child abuse, document it very well. You just can't say, like, again with a drunk person, like there was a handprint on the patient or that you suspected. It's kind of a delicate how you put it. You just say, well, there was an raised or red area that looked like consistent with a handprint. It was ecchymosis or whatever, multiple bruises of healing on the patient. And if you're involved, that you have to, your partner should be, and then like report it. Just let your chief know, like, this is what, or your supervisor know that this is, you had an abuse or you had an elderly abuse. Like you got to be an advocate for your patient as well.
Right.
Sometimes. So, and you just can't say, oh, I transported the patient, it's their problem now. Like you need to make sure, because it's just due diligence.
Right. To kind of add to that a little bit more too is it's not just so much abuse, but also neglect.
Yeah.
And again, we're not out there, like if I go to a call and I see different shades of bruising and things like that on a child, I'm not going to say to the parent, you're an abuser, I'm taking your kid. Right. We're just going to say, okay, we need to take the child to the hospital, and then we report that on our own. We just don't falsely accuse somebody until, guilty and innocent until proven guilty, utilizing that method. I had a case where, again, I'm leaving names and towns out of this, where we responded to a daycare for a 1-year-old with significant with burns at a daycare. And it ended up happening where the child care worker was holding the infant in her arms while boiling a binky, and the hot water spilled all over the child. Now, accidents do happen, right? Things can happen, and that's not really considered neglect or abuse. However, they called 911 after waiting 45 minutes for the mother to show up and told the mother that the burns were not significant. Mother got there and said, "Are you kidding me?" Called 911. We show up, and I got a 1-year-old with about 60% thermal burns from hot water from the head down. So I ended up giving the kid intranasal fentanyl, transported to the local hospital. And then because I was also working for the service that did the transfers out of the hospital as well, I took the kid to Shriners Burn Center in Boston. So again, accidents happen. Will there be a lawsuit? Maybe yes or no. But the part that was neglect was the fact that the facility refused to call 911 and made this child suffer in pain for 45 minutes. Now, was that child abuse? No. Was it neglect? Yes. And that's still something that needs to be reported. And that was reported. And it took a year and a half for that case to finally be closed, where that daycare center then got fined. But it was good documentation and good patient care and things like that helped with the case and what happened, because the daycare center said that they had done nothing wrong. But looking at the times of the call, getting dispatches times involved and everything else, when the time they subpoenaing phone records, they found that the call was made and 45 minutes later, 911 was called, and that was negligent. So again, was it child abuse? No. Was it negligence? Yes. And we still have to report that as well. And Morgan mentioned something about dog bites in the previous slide. That does have to be reported by New Hampshire state law, but we don't do it as EMS providers. The hospital takes care of that. I'm pretty sure you mentioned that. I just want to kind of reiterate that New Hampshire does require dog bites to be reported to the town authorities. So hopefully that helped a little bit more, Morgan, with the case that I had.
Yeah, it does.
All right.
I haven't had anything really. Any other questions, comments while we're? Oh, there's a cat. Okay, move on.
Mr. Cat wants to participate in the lecture today.
All right. So most states have reporting obligation. Again, we do not report sexual assault or rape. We document it, and when we drop the person off, if we are involved, we let the ER know. You can pull like the provider aside or the nurse and let them know in private. We do not document restraints or scene of a crime. That you would, if you ever come, I think that comes up in the next chapter. If you just back out and call the police. We do, in a way, we require, we report to the deceased patients. We just call the police and they call the medical examiner. Like, and if you're always like, if you call a time, like if you call a patient dead and on scene, you just mark the time, like time of death of, and then because the medical examiner is going to want that and the police are going to want that too. So ethics is a philosophy of right or wrong, moral duties, and so it's like our ideals, like what we feel is right or wrong. So like this question is if we somebody who's 90 years old goes into cardiac arrest, is it ethical to do CPR on this patient because it's a violent act if you've never seen it? Yes or no, like there's no right or wrong answer. Some people would say, yeah, we have to provide all the care we can. On the other hand, that's a violent act and they're at their end of their life. Do we really want to put the family and that patient through it? The morality is a code of conduct affecting character. Like it's pretty similar to ethics. Like just somebody's character, like code, like how they carry themselves and what they feel, and how they act. Bioethics is again, it's ethical, but within healthcare system.
So let me ask a question to the class then, in regard to ethics, because this is something that's going to come up in your career at some point in time. You respond to a residence. Again, I know you guys haven't gone through assessment yet. You respond to a residence for a patient on hospice, right? Patient's in cardiac arrest, not conscious, not breathing. The family approaches you and said the patient just went on hospice today. They have stage 4 cancer, lung cancer, with Mets. Okay, so it metastasized throughout the body. Patient's in cardiac arrest. The family wishes that you do not do any resuscitative efforts to the patient, but there is no DNR because they haven't gotten that far in the process yet. But they just started the hospice process that day. Do you do CPR or not? What's the question for the class to answer?
I would do CPR.
Do you think that's the right thing to do?
No, but I
Okay.
think that would be the legal thing to do. There's no DNR. Although I
Right.
worked for hospice and there was, when we'd put them on the first day, they had a DNR. So
Does it
it's
always
a very,
happen?
exactly. It'd be a very rare instance.
I bet that happened more and more commonly than you can even imagine.
Wow.
Yeah.
So what would you guys do?
I think it should be left to the family.
We got the echo going on.
Mhm.
So what else could we do? Should we call anybody?
I mean, I can give you a very personal story. My husband's mom passed away about 7 months ago, 8 months ago now. She was at one point a DNR. and then went into a hospital stay, ended up coming home not on a not as a DNR. She was very sick. She had COPD, she had CHF, a lot of problems. And her husband found her unresponsive on the kitchen floor. Tried to start CPR. They came. She was, I mean, in my opinion, I've worked in a hospital setting. I've done a lot of hospice care. In my opinion, no one should have ever started CPR on that woman. I mean, they broke every rib. She never regained consciousness. She should never have been given CPR, but she was. They
Right.
transported her. We, you know, we she lived on life support and main med for several days. The day we decided to say goodbye was the day she decided to pass on her own. But I, I'm not sure that CPR was the right decision, even though legally maybe it was. I mean, she had come home and changed her status. Actually, I think it was a combination of her family, but I think she should never have been. She just shouldn't have been given CPR. She just shouldn't have.
Right.
But
So Jason had mentioned in here as well, and that's actually the correct answer, is you contact online medical control and you
uh,
ask permission to not do CPR, but paint the case as well. So online medical control can make that decision based upon the current conditions that are there. So have consultation, have that conversation with them and saying, I'm on scene with a 95-year-old male who's got stage 4 lung cancer, metastasized. Patient is currently unresponsive, not conscious, not breathing, started hospice today. DNR is not currently in effect, or if it is in effect, I don't have the paperwork yet at this point in time showing that it's in effect. Can we not do CPR? Can we call this now? And a lot of times the physicians will say, yes, go ahead and do that, because they pass peacefully at home. The last thing you want to do is bring them back and be on, like I said, life support, and then put them into the ICU or the hospital, into the intensive care unit. Now the family's racking up even more of a bill on top of that. There's a lot of other complications that go beyond that if that were to happen. So again, medical control can be your friend. So like I kind of want to mention that with ethics, because ethically we all want to help out. We want to do the right thing, but is doing the right thing really doing the right thing? What's going to be best for the patient? What's best for the family? The only way to deviate from protocol is going to be medical control. So I kind of want to throw that ethical thing out there, because ethics can be tested on a daily basis. You just got to be ready for it. All right. Sorry, Morgan.
No, don't be sorry. I appreciate it. So ethical required you evaluate apply ethical standards like the case that Kevin just did, and of your own and those of the professions. Allow rules and laws and policy to guide your decision making. Like again, that was a really good case. Like a rule would be to start CPR. But again, you can like call medical control and like, hey, this is what's going on. The EMT in court, the one place we never want to be. I've never been in a court case and I don't want to jinx it as a provider. So we can be a witness on a scene, or we can be a defendant in a civil or a criminal case. Like, so if we're on like an accident or whatever, I've as an administrator, I've seen a few weird things come up. Like somebody stole somebody's house actually as an elderly person, sent it to the nursing home, and then the state wanted the records um, for that our call. So the documentation was sent as a witness. Um, Again, it can be civil. Like if I didn't provide the care like the family thought I should, they can go after me civilly or criminally. Like if I did something legally wrong, I could be fined or put in prison. Whenever call, yeah, if you're ever called, like lawyer up immediately. Let your director know. And as a witness, I guess if you've ever been to court, just remain neutral. They're probably gonna run you through the ringer and review the document before you say anything about it to either side of the party. As a defendant, again, get a lawyer. Um, I guess some defense of the statutes of limitations. I think it's like 10 years in New Hampshire, or if they have to, and then you have to prove if you're negligent or not, and if you're have immunity. So it's a long process. Like Kevin's case with a kid, we said a year and a half, which I believe. Just calling will, like, you have to call and give a recording that you want to report it. Then it's like a week later before they talk to you. So, but on discovery side, like both the defense and the prosecutor will interrogate you to gain like all the information they need, and it's pretty detailed. They want written requests or questions, or they're going to give you written requests or questions, and then you can answer orally. Most cases are settled out before they go to trial, like after the discovery phase. Like if you were truly negligent, then they can settle. Like if you just pay whatever or a percentage, so it doesn't have to be dragged through trial, because that gets expensive for everybody. And if it doesn't get settled, you'd have to go through the trial, and there's a jury, and then the judge, if they say guilty or not guilty, and the judge can decide how much punitive damages or the fine or punishment should be. If an EMT charged with a criminal offense should be secure services of a highly experienced criminal attorney immediately. So true. Yeah, so if you ever get called in, like if you're a defendant, just lawyer. Oh, so we're at the end for the review. You arrive at the scene of an older woman complaining of a chest pain. Then assessing her, she holds her arm out to take her blood pressure. This is an example of implied A, compliant consent, B, informed consent, C, express consent, or D, emergency consent. It would be C, because she's expressing consent to be evaluated, right? Yes, express consent. Patient authorized you to provide treatment, either verbally or non-verbally. Yeah, somebody holds their arm out. Would be expressed. Which of the following is an example of abandonment? A, an EMT leaves the scene after competent adult is refused care. An EMT transfers patient to an emergency department nurse. An EMT transfers patient to transfer care to a patient to a paramedic. Or an AEMT transfers a patient to an EMR. D? Yes, definitely D. Because that would be going down, and EMRs can't do patient care at all. So the unauthorized confinement of a person is called A, assault. Excuse me. A, an assault. B, battery. C, false imprisonment, or D, slander. D, yes. We've imprisoned them without their permission. Failure for the EMT to provide the same care as another EMT would be the same training is called libel. A, libel. B, slander. C, negligence, or D, abandonment. D, yes. If I don't. An 8-year-old boy who was struck by a car is unconscious and bleeding from the mouth. A police officer tells you that he is unable to contact the child's parents. You should A, continue to treat the child and transport as soon as possible. B, cease all the treatment until the child's parents can be contacted. C, continue the treatment with authorized medical control. Or D, provide area management until the parents are contacted. A. Anybody have anything else besides A? No. Yes, A. Because you're acting in good faith and you don't want to. Kids are scary, and you want to get them where they need to be as soon as possible. An advanced directive is a set of specific guidelines that clearly defines types of consent. A formal list that defines by state law whether a patient has decision-making capacity. A written document that specifies the care you should provide if the patient is unable to make decisions. A verbal order given to you by a dying patient's family regarding whether their treatment should be provided. That's a good question. C, everybody's saying C? C. So yeah, it's a document that states what we can and cannot do. They're incapacitated. Which of the following is patient is competent and can legally refuse EMS care? A confused young female who states that she is the president. A man who is staggering and states that he's drank only 3 beers. A conscious, alert woman who is severe pain from a broken leg. D, a diabetic patient who has slurred speech and is not aware of the date. C, it is C. Good job. You're treating a patient with apparent emotional crisis. After the patient refuses treatment, you tell him that you'll call the police and have him restrained if he does not give you consent. Your actions in this case are an example of A, assault, B, battery, C, negligence, D, abandonment. C, negligence. Why would you say C? I'm curious. A. So the answer is A, because you're trying to coerce the patient into doing something that which I've actually seen a few times. Is yeah, you're providing assault. You're putting fear into their. It's not really negligible, because you're, I guess, acting in good faith, but and you haven't really done any patient care other than trying to do what's you think is best for the patient. That answer's clear. Or, the EMT has a legal duty to act if he or she is off duty and witnesses a major car accident. B is a volunteer who's on duty and is dispatched on a call. C is paid for his or her services but is not on duty. D, out of his or her jurisdiction, sees a man choking. B. Yes, it would be B. Kevin gave a good example of that. Which of the following statements about records in the reports is false? Illegally, if it was not documented, it was not performed. B, a complete, accurate report is important to safeguard against legal problems. C, an incomplete or untidy Patient care report is evidence of incomplete or expert emergency medical care. D, your patient care report does not become a part of the patient's hospital record because the treatment was provided outside of the hospital. Ooh, that is a good question. I don't think we covered it. So we can break it up. Legally, if it was not documented, it was not performed. Legally, you can still perform it and not document it or whatever. That's just, I don't like that statement, and I've heard it. You should document everything you do, and if you don't do it, you should still document it and why you didn't do it. Complete and accurate report is a safeguard against legal problems, which is false. You can always have legal problems no matter what you do, but it's a good defense.
D.
So, what? D? Somebody say D?
D.
D. Yes, it is D. Good.
Yes.
Sorry. Done. We're done. All right, let's take like a 5 or 10 minute break. Stretch. Then we go through
5 or 10. Which one?
Let's see you guys back at 7:50.
All right.
There you
Good
go.
call.
All right.
Thank
I
you.
like that call.
Yeah.